Let's study about thyroid function test. The hormones that are secreted by thyroid gland are T3, T4 and calcitonin. In thyroid function test, what test we do? First is serum TSH. This is measured by immunoradiometric assay. In short, we can say TSH-IRMA. This is most sensitive index of thyroid function. If its levels are decreased or suppressed, then it indicates primary thyrotoxicosis. If its levels are elevated, then it indicates primary hypothyroidism. Besides primary thyroid disease, TSH levels can also be increased in certain other conditions. TSH value should always be interpreted along with T4 assay. So when we do TSH or serum TSH, we also do T4 assay. And the conditions in which TSH levels are increased are severe non-thyroidal illness. मतलब the conditions in which TSH levels vary also includes severe non-thyroidal illness, that is also known as sick euthyroid syndrome, TSH secreting pituitary tumors, first trimester of pregnancy, high doses of corticosteroids, secondary hypothyroidism caused by hypothalamic pituitary disease may produce low normal or normal high levels that are inappropriate for the very low free T4 level. So serum TSH is measured by immunoradiometric assay and it is decreased in primary thyrotoxicosis and increased in primary hypothyroidism, and it is also decreased in first trimester of pregnancy and with high doses of corticosteroids, and secondary hypothyroidism is caused by hypothalamo-pituitary disease. Next we can do is TRH test, thyrotropin releasing hormone test, and TRH is released by hypothalamus. Plasma TSH levels are measured before and after intravenous administration of TRH. Failure of plasma TSH level to rise indicates primary thyrotoxicosis. This test is not used nowadays as sensitive TSH assays are available. Serum free T3 and free T4. Advantage over the measurement of total T3 T4 is that these are not influenced by the changes in the thyroid hormone binding globulins, prealbumin and albumin. So free T3 and free T4 is not influenced by changes in the thyroid hormone binding globulin. In patients with primary thyrotoxicosis, free T3 and free T4 levels are elevated. In patients with T3 thyrotoxicosis, free T4 and free T3 levels are free T4 are normal and free T3 levels are raised. In patients on T4 therapy, free T4 levels will be raised and free T3 levels will be normal. So in patients with primary thyrotoxicosis, T3 and T4 will be elevated. If there is T3 thyrotoxicosis, then T4 will be normal and T3 will be raised, and if we give T4 therapy to the patients, then free T4 levels will be raised and T3 level will be normal. Let's do this total serum thyroxine. In total serum thyroxine, it is altered by the factors, that is concentration of thyroid hormone binding globulin. Raised levels are present in hyperthyroidism, in pregnancy, estrogen therapy, tamoxifen, and congenital anomaly. Depressed levels are seen in hypothyroidism, can also be seen in nephrotic syndrome, androgen therapy, liver failure, drugs like salicylates, sulfonylureas, and phenytoin. Total serum triiodothyronine, it is also as same as T4, and it alters reverse T3. Reverse T3 is produced by small amount in thyroid gland, and it is principally the product of T4 degradation in peripheral tissues. It is elevated in subjects with high TBG. It is normal in hypothyroid patients that are treated with thyroxine, indicating that peripheral T4 metabolism is an important source of circulating reverse T3. Uptake of radioactive iodine or technetium. Overactive gland synthesizing excess T3 has an increased uptake of iodine. Increased uptake is demonstrated by giving an oral tracer dose of iodine 131 or 121 and measuring the thyroid uptake after 4 hours using a counter over the neck. Alternatively, we can also give technetium 99 intravenously and the thyroid uptake is measured.